the group of tendons that stabilize the ball in the shoulder socket. If a torn rotator cuff is not repaired, arthritis may develop in the shoulder. The surgeon begins by identifying the tear in the rotator cuff tendon. The cuff is brought over to its original attachment site to ensure that the repair can be completed without tension. Once the bone and soft tissues are prepared to reattach the cuff, the surgeon creates a bone socket. A corkscrew FT anchor containing sutures is placed in this socket, and the sutures are then passed individually through the rotator cuff from bottom to top. The suture is retrieved and stored in a cannula. The process is then repeated with a second anchor. Sutures in the second anchor are a different color to allow the surgeon to easily distinguish them from the first anchor. For average-sized tears, 2 medial anchors are used. The surgeon then creates 2 additional sockets laterally. Sutures passed previously are crossed and secured to the bone using knotless push-lock anchors. The double-row rotator cuff repair is complete when both sutures are securely fixed to the bone in all 4 sockets.
To keep the joint stable, a set of 4 ligaments keeps the knee in a hinge-like position while you move. 2 ligaments on either side of your knee joint, the medial and lateral collateral ligaments, connect to either side of your femur and tibia and limit shifting movement left or right. The other 2 ligaments, the anterior and posterior cruciate ligaments, connect from the base of your femur to the top of your tibia. They cross each other and prevent the knee from excessive forward and backward movement, as well as twisting movement in either direction. Start the procedure. The surgeon will insert a probe to inspect the damaged joint. A small motorized shaver will then be used to remove the damaged ACL and prepare the area for the new one. Then, the surgeon will use a device called a retro flip cutter to create a tunnel through the femur and into the knee joint. The surgeon will also create a tunnel through the tibia and into the knee joint from below. These 2 tunnels become the source of the anchor points for the ACL graft. In most cases, the surgeon will harvest a portion of your own hamstring tendon to use as the graft. Using your own tissue reduces the likelihood of your ACL rupturing again, and is a reason some surgeons decide not to use a tendon harvested from a cadaver. A surgeon will harvest more hamstring than needed. Your surgeon will prepare the harvested hamstring and pull it through the upper hole and into the lower hole just taut enough to mimic your original ACL. A small grappling hook will anchor the upper end of the graft, and a screw will stabilize the lower end. The screw is usually bioabsorbable. The graft from your hamstring tendon will act as a scaffold upon which a new ACL will grow. Over time, the hamstring